Welcome to the Explainer. Today we are tackling a true neurological emergency, encephalitis. We're going to do a deep dive here, focusing specifically on two of the most critical and, really importantly, treatable infectious causes.
All right, so where do we even start with something this complex? Well, it all kicks off with that initial clinical suspicion. You know, that critical moment when a patient comes in and their symptoms just scream inflammation of the brain.
And let's be absolutely clear about this. We're not just talking about a bad headache here. Encephalitis? I mean, this is an active, aggressive inflammation of the brain parenchyma itself. Right from that very first moment of suspicion, the stakes are just incredibly high. It's a true emergency.
Now, you know, encephalitis can be caused by a lot of different things. But for our purposes here, we're really going to zero in on two of the big infectious players. And the reason we're focusing on these is because they're not just significant, they are, crucially, treatable. We're talking about Herpes Simplex Virus, or HSV, and the parasite Toxoplasma gondii.
And this right here, this is what makes Toxoplasma so tricky, so insidious. It's not a pathogen that just hits and runs. No, instead, it forms these tiny intracellular tissue cysts, basically setting up shop and hiding out in the body for life. They can just sit there, dormant, for years, even decades, and then, if the host's immune system takes a hit, they can reactivate and cause devastating disease.
Okay, so you've got this strong clinical suspicion. What's the next move? How do you actually confirm what's going on? Well, anytime you suspect something is happening in the central nervous system, the answer, really the key, lies in the cerebrospinal fluid, the CSF.
And this workflow you see here, this isn't just some friendly suggestion. It's a flat-out race against the clock. I mean, every single minute you delay getting that lumbar puncture and analyzing that CSF sample, that could be the difference between a full recovery and, frankly, permanent neurological damage.
I like to think of this CSF panel as, well, it's like you're building a legal case against the pathogen, right? The cell count and the protein levels, that's your circumstantial evidence. It tells you, hey, something is definitely wrong, there's inflammation here. But the PCR test, that's the DNA evidence. That is the smoking gun that says, we got him. This is the culprit. And then, the antibody index, that's the confession. It's proof that the immune system isn't just fighting somewhere in the body, it's mounting a specific, targeted attack right there inside the central nervous system.
All right, so identifying the bad guy is one thing, but knowing how to actually take it out, that's a whole different ballgame. And this next part, this is where the lab really becomes the quarterback, guiding the entire therapeutic strategy through susceptibility testing.
It's so important to understand just how different these two culprits are at a fundamental biological level. You've got HSV, a virus, right? It's neurotropic, it loves nerve cells, it replicates, and then goes latent. On the other hand, you have Toxoplasma, a protozoan parasite, which forms those persistent tissue cysts we talked about. And this isn't just academic. This difference dictates everything about our therapeutic approach, from the type of drug we choose to how long we treat the patient.
Yeah, so AST, or antimicrobial susceptibility testing, this is not just some intellectual exercise we do in the lab. It is the absolute cornerstone of modern evidence-based antimicrobial therapy. It's what gives us the hard data, telling us which drugs are going to work and, maybe even more importantly, which ones are going to fail.
Now, when you look at these categories, the real clinical sophistication here is in that I category for increased exposure. It's not just a maybe. It's the lab sending a very specific message. It's saying, look, this drug can work, but you're going to have to hit the pathogen harder. This is what allows for true precision medicine. We can adjust the dose, change the frequency, optimize the therapy to beat the bug, instead of just giving up on a potential useful drug.
Okay, so we've got our diagnosis confirmed, and thanks to susceptibility testing, we have an idea of which drugs should be effective. So let's get into the specifics, the evidence-based treatment protocols for adults.
When it comes to HSV encephalitis, the protocol is crystal clear. It's really non-negotiable. We're talking high-dose intravenous acyclovir. That's 10 milligrams per kilogram given 3 times a day. This is the undisputed standard of care.
and it has to be started as early as humanly possible, ideally right when you first suspect it, and then continued for at least 14 days, sometimes longer.
Now, for toxoplasmosis, we have to completely switch gears, removing away from antivirals and into antiparasitic drugs. The gold standard here is a classic 1-2 punch, a combination of pyrimethamine and sulfadiazine. And if that's not an option, a common alternative is high-dose cotrimoxazole, which is nice because it gives you the flexibility of either IV or oral administration.
You know, the combination of pyrimethamine and sulfadiazine is such a classic choice for toxoplasmosis. You could almost say the two agents have excellent synergy. Okay, a little microbiology humor for you there, but it's actually the perfect word for it. The synergy is very real. These drugs work by blocking sequential steps in the parasite's folic acid synthesis pathway. So by hitting it from two different angles, the combination is just way more powerful than either drug would be by itself.
But what happens when the patient is a child? This is so important. You have to remember that kids are not just miniature adults. Their physiology is completely different, and you can't just take an adult dose and scale it down by weight. That's especially true when you're talking about newborns.
I really can't overstate this next point. Neonatal herpes is its own distinct and uniquely devastating disease. Trying to use an adult dosing regimen in a newborn isn't just inappropriate, it's incredibly dangerous. Treatment must be guided by dedicated pediatric formularies. No exceptions, period.
And here's another one of those subtle but potentially life-saving details, this time for pediatric toxoplasmosis. So you might decide the right drug is cotrimoxazole, but the formulation of that drug could be wrong. See, the intravenous version contains propylene glycol, and that excipient can actually be toxic in kids under 5. This is a critical point that forces you to consider alternatives, like switching to an oral formulation or a different IV product altogether.
All right, let's start to bring this all together now. We're going to look at what this means from a public health perspective, what the long-term outlook is, and then we'll put our knowledge to the test with a classic clinical case scenario. This actually reveals a really key public health principle. The goal isn't necessarily to track every single sporadic case of HSV encephalitis. It's about detecting a signal in the noise. Public health authorities are on the lookout for unusual clusters, anything that might signal a potential outbreak. That's what represents a broader public health risk and would trigger a major response.
Okay, knowledge check time. Here's your case. You have a 45-year-old, otherwise healthy patient who presents with that classic triad: acute onset fever, altered mental status, and focal neurological signs. Your CSF analysis comes back, it shows pleocytosis, and the PCR is positive for Herpes Simplex Virus DNA, a textbook case.
So what's the call? Based on everything we've just discussed, what is the indicated first-line intravenous therapy that you need to start, like, right now?
The answer, of course, has to be high-dose intravenous acyclovir. Its mechanism is just so elegant. Think of it like a Trojan horse. The drug is a prodrug, so it only becomes active once it's inside a virus-infected cell. And once it's activated, it just slams the brakes on the viral DNA polymerase. It stops viral replication cold. And that action is what gives the patient the best possible shot at a good neurological outcome.
And that really leaves us with a final, forward-looking thought. We said it again and again. With encephalitis, treatment is a race against time. That window, from the very first symptom to the first dose of the correct drug, is probably the single biggest factor determining a patient's outcome. So the question becomes, as our diagnostic technologies get faster and faster, how will that ability to shrink that critical time window reshape the future of how we manage this truly devastating disease?